Okay. Ek wil net goeienaand sê of en ek dink ek gaan maar onmiddellik oorskakel Engels toe want ons net om seker te maak almal verstaan wat ek sê. So welcome everyone at our special edition support group meeting for breast cancer October Breast Cancer Awareness Month. And I just also like to welcome our, shall I say, guest speakers. Let's start with the lady, Lori and Vivek. Thank you very much for being here this evening. And I'm sure you're all very impressed with her pink hair, especially for the occasion. And then also Dr. Ettienne and Lori. Ettienne, welcome here and thank you for being willing to share your expertise and knowledge regarding the treatment of breast cancer. So with no further ado, I'm just going to hand it over to the two of you.
Thanks, Marlies. Yeah, I mean, I tried to dye my hair pink, but maybe you know it's the tresemme that I tried that obviously didn't work so well. So I think that's why it came out this color. So I decided I'd at least sort of wear it.
I forgot to mention Etienne's pink tie. That also I think deserves a.
So I had to do a little bit of pink at least, you know. So what do they say? Real men do wear pink.
Yeah.
Okay. So yeah. So I think the last couple of support group meetings we've had guest speakers, people coming to sort of share a little bit of knowledge, some of the topics on breast cancer. And Lori came with this idea, maybe she should sort of pepper me with a few questions about breast cancer. And I think she sent out the invitation into the cloud, you know, to hear what people want to know. And I see she's come prepared. It looks like a Donald Trump speech or something. Yes. So we'll see what she ends up. And you know, I've tried to sort of convince myself it's not an exam, so I don't have to stress too much about not knowing the answers. But bear in mind, I always say one thing. What you need to know about surgeons are that they are frequently wrong, but they're never in doubt. So whatever I tell you tonight, just bear that in mind, that I might be frequently wrong, but I'll try not to be in doubt when I give the answers. So all right, Lori Ann, shall we fire away?
Yeah.
I'm gonna try and zoom in a little bit closer, so we don't get completely lost in the thing. And at least if you know, I want to also say, if you have questions, you can post them online on Google Meet, and then Marlies will sort of throw them if she thinks that Lori's questions are not difficult enough, she'll throw them from the side. Yeah, so I'm ready.
Okay, so I'm going to go with the first one, Gillian. Gillian wants to know, are tumor markers a good indicator to detect active cancer?
So the short answer for breast cancer is no. Okay, so we have a few cancers that actually do have good tumor markers, things like testicular cancer and germ cell cancers, and maybe even prostate cancer, where we can test for PSA in the blood. But in breast cancer, we have two markers that we frequently use. The one is BR 15.3, and the other one is CEA. And these markers can sometimes go up with breast cancer, but they can also go up with things like, you know, chronic obstructive airway disease and bronchitis and things like that. So they're not very good. So number one is they're not good to diagnose breast cancer. So they're not a good way for you to find out whether you have breast cancer. And secondly, they tend not to go up in early breast cancer. So if you have a patient that has widespread breast cancer and the markers are high, and we give you treatment and they come down, it helps us to say, okay, we think the treatment's working. But if the markers are normal, it doesn't mean that you don't have breast cancer, and it also doesn't mean that the breast cancer hasn't spread. So not very good. And in fact, whether you do the markers during follow-up or not, it seems not to make any difference in how well the patients do or don't. So yeah, one shouldn't, I always warn the patient to say, please don't sort of get completely upset by, what is my marker showing? Are they better or are they worse? They one of the little things that we look at, but they're really not that important.
Okay, now I know for me, with stage 4, my breast cancer marker was 0.
Yeah, exactly. Yeah.
Great. So then I've got Wendy. Wendy says she's a stage 1 hormone-sensitive breast cancer patient. Doctors found her breast cancer when she had a breast reduction. She completed 15 radiations. She's on Laradex and Flexical, and her genetic testing is negative. Now she wants to know, what are my chances of getting cancer later? What is the stats out there, Dr. Ettienne?
Well, obviously, Wendy, and I think everybody is, to say that the average woman will have about anything between 8 and 12% risk of getting breast cancer somewhere in your lifetime. So if you've had breast cancer once, then you still have another sort of, let's say, average 10% chance that you can have another new breast cancer again. If you have a genetic test, so everybody that has a genetic test should see a genetic counselor. And I think one of the meetings we had, we spoke to Chantel, who's our resident genetic counselor. And part of that genetic counseling is not just to do a genetic test, but in fact to actually work out with your age, the type of cancer you've had, your family history, and the genetic test to see what your average or what your lifetime risk is of getting breast cancer. So part of what the genetic counselor's job is not just to do the genetic test, but actually to give you an answer to say your chance of getting breast cancer again in your lifetime is X amount. And that is one of the things that I would sometimes use to say, listen, even though you've had quite a sort of a low grade, or I don't want to call it a friendly cancer, but a less aggressive cancer, because of this risk assessment of yours, maybe it is something that we should consider the option of a risk reduction or a prophylactic mastectomy. But I think that is important, that every person should have an individualized risk assessment that should have been done by the genetic counselor when, or at the time when you had your test.
If she didn't have a genetic test, just being stage 1 hormone positive, and you are sort of gone through everything and it's clear, is there sort of still a chance of 10% for reoccurrence later on in life? Maybe.
Okay, so we have two different things. Okay, you have a recurrence of your current, so the cancer that you had in your breast, what is the chance of that cancer having little microscopic deposits that can then later flare up? So that is a recurrence of your current cancer versus developing a new independent cancer. So theoretically, let's say, Wendy had an estrogen sensitive cancer now, and then in 5 years' time, the patient comes and they're diagnosed with an estrogen insensitive or a triple negative cancer. Now, so that is obviously a completely different cancer. It developed in a different way. So your risk of having a cancer recurrence with the stage 1 breast cancer is supposed to be anything between, let's say, 3 and about 7 or 8%. Okay, so, and that is the chance of the original cancer then coming back again in the same breast, or maybe coming back somewhere else in your body. Okay, so the risk of getting a second cancer at the very best is going to be about, let's say, average 10%. Okay, if you don't finish your anti-estrogen treatment for 5 years, or if you have extra family history of it, or if you have very dense breast tissue, or all the other factors that increases your risk for breast cancer, will push that 10% up a little bit more. Does that make sense? That you have actually two different risks that you're talking about.
And on that one, on the 5-year, taking your tamoxifen or whatever estrogen blocker, I've had many questions. Many women have so many side effects that they want to stop it.
Yes.
And I know I've spoken to you about it. Please, in the red, tell them.
So the bottom line is that let's just say if you take the average breast cancer and you give someone chemotherapy for that breast cancer, let's say, estrogen sensitive breast cancer, you will reduce the chance of dying of that cancer by maybe about 15%. Okay, obviously there are some cancers that are much more chemotherapy sensitive, and there are some that are not. But think about that. So in other words, you're giving chemotherapy for 100 women, and out of that 100 women, 15 of them are going to get some benefit. Okay. If I give anti-estrogen treatment, I do a couple of things. Number one is I reduce the risk of having that second new breast cancer by at least 50%.
Sure.
Okay, so if you don't take a tamoxifen, instead of a 10% risk, your risk will be 20% just because you've had a breast cancer already. Okay, so you double your risk of getting a new breast cancer somewhere along the line. You will increase your risk of your original cancer coming back or spreading somewhere by anything between 30 to 40% up to 100% if you stop your anti-estrogen treatment.
Prior to 5 years.
And if you decide, listen, once a month I'm going to skip 3 or 4 or 5 days, or if you decide, listen, December I'm going on holiday and I want to look sexy in my bikini, and I don't want hot flashes on the beach, I'm going to stop it for a month. If you are not 100% compliant with that tablet and you're taking it every day, you will lose as much as 30% of that benefit just because you're taking a little bit of a skip every now and then. If you take 4 years and 6 months and you decide I'm going to take a shortcut, you're probably losing out on quite a big, substantial amount of risk reduction for yourself. So if you have an estrogen sensitive breast cancer, the worst thing you can do is to stop your anti-estrogen treatment. There's no short answer to that. And, the reality is, it costs you something not to die of breast cancer. It costs you in the sense of side effects and hot flushes and night sweats and vaginal dryness and all the long list of things that people have. So it's not, you don't take it because you sort of woke up one morning and thought, well, let me drink something, to make my life, miserable or whatever. So and therefore it is important. I mean, that's part of the thing why I feel strongly that people should see someone like a psychologist, because having a strong mind and having good motivation is really important. And reminding yourself about, why am I doing this? Why am I taking this? So it takes effort. It's like most things in life that are worthwhile. It takes effort. You don't keep your figure by not doing any exercise and eating whatever you want. It takes effort to decide, I am going to exercise and I am going to not eat that extra slice of chocolate cake. This takes effort to decide every morning, listen, I want to take this because for the next 20 years I'm going to have benefits from that.
So if you stop it prior to 5 years, you're taking that risk into your own hands that it might come back.
Definitely.
Okay, the hot flashes, that is it. You're going to have it. Whether you menopausal before you got breast cancer.
Yeah, if you've gone through menopause and you've sorted your hot flashes out, then chances are really good that they'll come back. And I am very concerned if someone says, listen, Dr. Mammoprint, I have no hot flashes, because that makes me concerned that in some way that tablet is not working. Maybe your body is not breaking it down or not metabolizing it appropriately. There are conditions that we worry that maybe it's not working efficiently. So I am concerned if someone says, listen, my tablets have not giving me any hot flashes at all. Some patients have very mild hot flashes. They'll say, listen, I do have them, but they're very infrequent and they really don't bother me so much. So and I would definitely say more. If I talk to patients after 5 years, so if I talk to people after 6 months and I say, listen, let's talk about your tablet, almost everyone will say, I want to stop my tablet. if I talk to that same patient group after 5 years and I say, okay, listen, let's now talk about another 5 years of treatment because you can have this and this and this extra benefit, then the majority of them will say, you know what, actually I've managed so well with this tablet until now that I would actually prefer to continue taking the tablet or taking some anti-estrogen. So it's definitely, at 5 years, most patients will say, actually it's fine.
I'm used to it.
Yeah.
The one lady, Nulani, wants to know, she's picked up weight, which we all do, and now why do you struggle to get rid of that weight? Even with a great eating plan, even exercising, it feels like it's going nowhere.
Yeah. So I don't know. I can't remember now, Nulani. So especially with chemotherapy, during chemotherapy, patients normally get cortisone.
Yes.
And as we all know, cortisone does, gives you fluid retention. It makes you glucose intolerant, so you develop sort of an insulin resistance. So patients do pick up quite a bit of weight, especially with the taxotere or the taxane part of their chemotherapy. Second thing is, so that's the one thing. Second thing is, when you now change your body's metabolism and you take the estrogen away, then you are changing your body's metabolism, that the rate at which your body burns fat gets a little bit less. So that if you just continue with your same old habits, then you are inclined to pick up weight. In fact, most women, as they get older, will pick up a few kilograms per decade that they are older than 25. So there are very few women that will fit into their wedding dress when they are 55. So it's just the natural, cycle of life. And everybody will say, I have to work harder at maintaining my weight as I get older. So, and then the last thing is when you hear that you have cancer, I always wonder, maybe the psychologist can answer that question, but just like a baby is soothed by sucking a dummy or by having some sort of oral soothing, there are lots of people that are being soothed by oral intake of food. So, and unfortunately, different from a dummy that doesn't have any nutritional value. If you're a comfort eater, you will tend to then obviously gain weight. So we know from the dietitian side, they'll say, patients, if you really monitor someone, let's say you had a little television camera following people around, and you actually look at what they really eat, but you ask them, what they ate, they'll record anything between sort of 40 and 60% of what they really ate. Most people don't think anything that you consume while you're on your feet. So they only think stuff that you eat is stuff when you sit down. Anything that you're eating while you're walking or while you're standing doesn't count. So, and obviously that's not true. So the reality is most people eat more than what they need. Most people comfort eat when they have bad news, and it's difficult to get out of that cycle. To break a bad habit is really difficult. And most patients will pick up weight, especially during the chemotherapy, and then the last thing is, because patients are feeling unwell and they are a little bit nauseous and they have radiotherapy and they have surgery, they stop exercising. And the majority of patients, if you ask them a year after their breast cancer, are you exercising? Most of them, the answer will be, no, I don't. So it's that combination of lifestyle that brings that on. And then,
The story about the estrogen that you don't have anymore, your body produces estrogen now from what? It's from your adipose.
So fat cells, yeah. So if you patients that are overweight, we know the risk of their cancer coming back is higher. And part of that is because especially visceral fat that's sort of inside your belly, that's the bad fat. That's the stuff that makes you insulin, resistant and glucose intolerant, and that also sort of drives estrogen production. So the fat cells store fat, and they have estrogen-like substances, so things that look like estrogen to the body, and the liver will break that down and change that into substances that will actually stimulate the estrogen. But lung tissue also produces estrogen, liver tissue does. So everybody, whether you are obese or, thin or whatever, even if you're postmenopausal, you still have a little bit of estrogen. That's why we treat patients with anti-estrogen tablets, even if they are postmenopausal.
Okay. Yeah, that's the one question I also wanted to know. So if you're menopausal, why, and you've removed your ovaries, why are you taking tamoxifen? Because your own body can still make.
Yeah, so in postmenopausal patients, we will tend to use a drug that we call an aromatase inhibitor. So it's something that switches off that production of estrogen from these peripheral tissues, from your lungs and your liver and your fat cells. In premenopausal patients, an aromatase inhibitor will not work on its own because it doesn't switch off the ovary. So it might still switch off the estrogen from the other parts, but the ovary is the biggest source. So in younger patients, premenopausal patients, we will tend to use tamoxifen, which is a blocking agent. So it blocks the estrogen from attaching itself to the cancer cell. On my channel, I have a little video that's with an animation of explaining sort of how the estrogen comes, attaches to the cell, and then stimulates that cell to grow. So tamoxifen blocks the estrogen from getting onto the cell. The aromatase inhibitors will block the production of the estrogen from that peripheral tissue.
What is the example of that?
It's letrozole or equison or...
What is Kezar?
Kezar is tamoxifen. Kezar, Neofidin, Tamoplex, those are all sort of different makes containing tamoxifen, which is the blocking agent. And Kezar, Aromasin, Equison, not Kezar, sorry, Letrozole, Femara, Stradexa, Arimidex, those are all aromatase inhibitors that patients use.
Great. So now the next question I have is, when do you go for your, there's a whole story about antiperspirant that contains aluminium salts. What is your take on that, using it after breast cancer, going back onto antiperspirant, or should you stay away from aluminium salt, deodorant? Do you have a...
I am not aware of any good prospective data, meaning that they followed lots of patients in the long term, looking at, let's say, half of the patients using antiperspirants and half not, and then seeing which patients have more cancers. Okay, so there's no data, there's nothing to support the fact that an antiperspirant will make your cancer come back. But antiperspirants, especially the aluminium containing ones, are the ones that are most effective. Now, if you use that in a patient who has had radiation and an axillary dissection and whatever, then obviously it can create blocked little sweat glands, and you can then develop little abscesses, or and obviously we know if you get an infection in that region after breast cancer treatment, it increases your risk of getting swelling of your arm. So in principle, we'll say, if you've had an axillary dissection or if you've had radiation treatment, you should be careful with very harsh antiperspirant type of applicators, because it can increase your risk to skin sensitivity and subsequent infection. But from a cancer perspective, there is no evidence that those things cause cancer or increases your risk of getting breast cancer.
Then Yana says she's estrogen progesterone positive stage 3. She got her implants before she was 30, and there's a story around the net that you can only have your implants for 10 years, or that you need to get replacement implants. Is that how it works?
So definitely not true. So your implants don't have a lifespan to them. Most companies will guarantee the implant from manufacturing defects for 10 years. So if your implant sort of starts leaking or whatever spontaneously, they'll replace that implant for free. But and that's obviously geared towards the cosmetic market, not as much to the breast cancer market. So in theory, if you have a prosthesis in, and it's a modern generation prosthesis, then you don't replace that prosthesis unless that prosthesis is giving you any trouble. So if it doesn't form a dense capsule, if it's not leaking, if it's not calcifying around it, if it doesn't move to a different position, you leave that prosthesis alone and you don't replace it routinely. There's some maybe it's died down a little bit, but at one stage there was this huge concern about a prosthesis related, and they would call it a lymphoma, a large anaplastic lymphoma that's associated with prosthesis. It's not a real cancer, it's not an invasive cancer, and there's like in the whole world where like millions of prostheses are put in every year, there's a little, a handful of cases. And at one stage, the companies were like, really, oh my goodness, we have to now take all our prostheses out of patients. And there was some concern about a textured prosthesis. If you have a rough prosthesis, that those things would cause problems. And I mean, there were some companies that even sort of withdrew and actually stopped making prostheses completely. And I think that is a complete overcall. We are definitely not phoning patients from 10 years ago and saying, listen, come back, we have to change your prosthesis. So no, if the prosthesis is not giving any trouble, then we don't have to worry. In South Africa, there has not been a single case confirmed of prosthesis-related sort of large anaplastic lymphoma. So I don't think it's something that really warrants exposing someone to surgery, because patients do die from surgery, even if it's minor surgery. So definitely the risk of going back for surgery just to have a prosthesis changed for no reason is not a good reason.
Then Jana also wants to know, she's obviously young and on tamoxifen. Is there what is a good contraceptive for her to be on? Because obviously you're not allowed to fall pregnant now when you're on tamoxifen.
Well, you shouldn't fall pregnant in the first year after your breast cancer. The evidence says if you do fall pregnant, then your prognosis is much worse.
Okay.
But if you fall pregnant, let's say 2 or 3 or 4 years after breast cancer, then your prognosis actually seems to be a little bit better. So even though you would have then not have taken 5 years of tamoxifen, so okay, so that's just the one thing about falling pregnant. But you cannot use anything that contains hormones. So that excludes all the oral, the pill, the injection, the Mirena, any of those things. So in principle, the safe things are like a copper T intrauterine device, which is what we tend to use if someone is fairly sure that they've completed their family and they don't want to have more kids, then I would definitely advise, the husband can do his little part as well and go for a vasectomy, and I feel quite strongly about that.
Okay, but she's still young. I think she's 30.
Okay, so
they still need to have their kids.
So I think if you still, want to maybe have kids, or you still haven't got children, you still want to have children, then I think a copper T is probably the best way to go. It's the most dependable way, I think, and then obviously the other alternative is condoms and abstinence, which both don't seem to work very well. Yeah.
Sheila was asking me, terrible joint pain, body pain after chemo and Herceptin. Does it get better? Joint pain, body pain. I also find joint pain.
Yeah.
But so is it Herceptin? Is it the chemo? Is it
no? So this is and I think you went through a little bit the same thing. Is so if someone just had chemotherapy and Herceptin and they have these complaints, I definitely will not say, listen, it's because of the chemo and the Herceptin. So from my side, that needs to be investigated to see if there's a different cause. I mean, remember, the patients can have rheumatoid arthritis, they can develop all kinds of other diseases that can actually cause that. So I would say an autoantibody screen where we look for antibodies that your body produces against joint tissue. That's rheumatoid arthritis type of things. And then the other thing that can catch you out is hyperparathyroidism, where you have there are 4 little glands in your neck next to your thyroid. We call them the parathyroids. And they produce a hormone that helps to control the calcium levels in your blood. And what can happen is one of those glands can become overactive, and then it pushes the calcium levels up, and that can cause all kinds of body aches and joint aches and of depression type of symptoms and chronic tiredness and very vague symptoms, and patients are frequently missed for many years because they have that. So if a patient then comes to me complaining of those things, I will test their calcium, I will check their PTH, I will do the autoantibodies and check whether they have any of these conditions. And frequently you find other things. Remember, the fact that you've had breast cancer doesn't now mean everything in your life that's not well is because of breast cancer.
Great. Then the next thing I have here is what is an onco score? Because now people talk about onco score.
So I think you're probably referring to an Oncotype DX. So Oncotype DX is it's a company in the United States that have developed a scoring system of deciding how bad your cancer is. What is the chance of you dying of your cancer? So what they did is they took lots of patients' cancers and they looked in the cancer itself. They looked at a couple of different markers, normally genes, things like the estrogen gene and the progesterone gene and the HER2 gene and RAS. And so they took those genes and they gave each one a little score. And so what you do is you send your cancer tissue to them, they test that, and they give you a score anything between 0 and 100. And what it means is if you have a score of 10, your risk is half of someone whose score is 20. It doesn't tell you if your score is 10 that you have X% chance of dying of cancer. And it also doesn't tell you very much about whether chemotherapy will help. So we know if you have they have a low score, an intermediate risk score, and a high score. If you have a lower intermediate score, adding chemotherapy to your treatment really doesn't seem to give you much added benefit for survival. If you have a high risk score, then theoretically adding chemotherapy does help. So the Oncotype DX score is a score that's being used to try and sort of decide what your risk is in a more objective way versus just looking at the staging, for example.
The other thing I want to know is the whole story about the Mammoprint. So that's when you send your breast tissue away to have it done. But now not everybody does that.
No. So Mammoprint is the European what shall I say, competitor to the Oncotype DX score. And I think if I look at the science behind those two tests, our feeling is that the Mammoprint score is it's a more robust, it's an independent piece of information. So if I look at the Oncotype score and I compare that to the normal things we normally do, estrogen and HER2 and the Ki67, it correlates fairly well. And it doesn't really, I just find it doesn't give me that clear information. Whereas Mammoprint says you're a low risk or you're a high risk cancer, doesn't make use of those known things. And with Mammoprint comes a test that we call Blueprint. So the two go hand in hand. So Blueprint actually tells you whether your cancer is a luminal cancer, in other words, a hormone-driven cancer, whether it's a basal cancer or whether it's a HER2-enriched cancer. So it is, I always talk about it as being a personality test for the breast cancer. So it doesn't worry about how big the cancer was, whether the cancer is estrogen positive or negative, whether you had lymph nodes involved or not. It looks at the cancer cell, it looks at the programming that goes in the cancer cell, and it will give you that high risk, low risk answer. And we know if you're a low risk patient, adding chemotherapy to that patient's treatment doesn't make any difference. Even at almost 10 years down the line, it still makes no difference. If you're a high-risk patient, adding chemotherapy does actually make a much bigger difference. It improves the survival by 25% instead of the average like 15%. So in my mind, Mammoprint does two things. It firstly gives me a yes or a no answer for chemotherapy. And it's especially important because it's been validated in patients that I would say you need to have chemo, but if your Mammoprint is low risk, we can omit that chemotherapy. And we have in South Africa over 600 patients that we've used that on over the course of many years, and it's a very good and accurate predictor. The problem with both these tests is Mammoprint is about 35,000 Rand. Oncotype DX, I think, is in excess of 40 or 45,000 Rand, so it's very expensive. And unfortunately, there are only very few medical aids that will cover that. And even a medical aid like Discovery that does cover it will only cover it for very specific situations. So in theory, I can actually do a Mammoprint even before I do your surgery so that I can decide do you need to get chemotherapy up front. They won't pay for that in that scenario, although it's a very valuable way of deciding that.
So one of the ladies that I met, she had, I think it was an estrogen sensitive one, which wouldn't have received any chemo. But yes. I think they did the mammo or the blueprint and it came back high risk. Then eventually you switch it. But obviously if she never had it, she never would have received chemo. Just on a general...
Yeah, and the evidence that we currently have, the long-term research says that if you have a clinically, let's say you have a 10 millimeter estrogen sensitive cancer, no lymph nodes involved, so that's a low risk cancer, the chance of that cancer coming back is really small. Even if you have a Mammoprint high risk, it still remains so low risk that adding that chemotherapy doesn't give you a significant benefit in terms of outcome. So in principle, our protocol is, and that we would recommend for South Africa is that if you have a low risk cancer based on your normal pathology, that we wouldn't give you chemotherapy, that you shouldn't have a Mammoprint, and we shouldn't escalate your treatment because of that. I think in the old days, before we had these long-term research and outcome, there was this big trial called the MIND-ACT trial, where they tested that to see do the patients do better if you give them chemotherapy, even though they're actually a clinically low risk. And the answer was no, we didn't see a big improvement in survival.
Then one of the ladies wants to know how do you as doctors know, or the oncologists know, that the chemo is working? So now you take off with your whatever.
So we do chemotherapy in two settings. The one is what we call a new adjuvant setting. That means we do chemotherapy before we start with your surgery. And obviously, if you have a 5 centimeter cancer, or you have a cancer that's all over your body or whatever, and you give the patient chemotherapy and all of that shrink away, then you know the chemo is working. If your doctor decided to cut out that 5 centimeter cancer and there's nothing left and he gave you chemotherapy, there's no way of knowing whether that chemo is actually working or not. You give a standard recipe for that patient and you sort of hoping that it will help. So and I think that is a change in breast cancer. If I give talks and if I give advice to people, the one thing I always say is if you make a decision that the patient needs to have chemotherapy, then that chemotherapy should preferably be given up front. So if you already know you have a big tumor and you already know you have big lymph nodes, that patient should not have surgery. So, I would go as far as say no patient who has clinically big, palpable lymph nodes, none of them should have surgery up front. They should all have treatment to shrink the cancer first. It can be chemo or it can be anti-estrogen treatment, but you should have treatment first. You should not just be jumped in with surgery.
So normally after your red chemotherapy sessions, do we do a scan then? No. Only after everything you do a scan.
If you had your cancer out, and we say, well, everything's out.
Yeah.
And we said, well, but it's a high-risk cancer for some reason. We need to add chemotherapy to reduce your risk for the future. So we are giving you chemotherapy as a risk reduction. We don't know if there's really cancer left behind or not. Or we don't think there's cancer left behind, but we know that there's a risk that it can flare up. So we give you chemotherapy empirically. you would only do another scan. We do scans and things normally after a year because the thing is there's nothing to see.
But if you had a tumor now.
But if you have a tumor,
Yeah.
so if you have a clinically big palpable tumor in your breast and say the rest of your body is clear, that tumor will be checked every couple of weeks to make sure that it's shrinking. And I'm not going to do a scan unless the tumor is not shrinking or unless it looks like it's getting bigger. If it's not responding as it should. Obviously, if you have a tumor in your breast and you have things in your liver or in your lung or whatever, and you then decide to give chemotherapy, and this thing is shrinking, you want to know that the other things are also, then you would do a scan, and we'll probably do a, if the breast is responding well, we're not going to do a scan after the red chemo. But let's say the tumor after the red chemo didn't shrink that much. Then I'll say, okay, let's do a scan now just to see what's happened to the rest so we can make a decision what type of change we have to make.
Yeah, because the one lady was asking, so you can go through everything to find out it didn't work.
Like you should know that it didn't work. After if your cancer doesn't, if you start with chemotherapy and after 2 sessions there's no difference, then we would normally be worried that it's not working and we would need to want to make a change.
Yeah. Then I've got a question. How long do you need to wait between chemotherapy and getting a mastectomy? So you finish your chemotherapy, now you need to go for mastectomy. What is the average?
So we have two things. The one is that obviously the chemotherapy knocked out your some of your white cells and made you more susceptible to infection. So you want to allow your bone marrow to recover. So generally we'll say, okay, maybe 3 weeks or so. And obviously I want to have the full effect of the chemotherapy to kill the cancer. And that can sometimes be, let's say 5 or 6 weeks after the last chemo that you still see cancer shrinking away or dying away. So in general, we'll say longer than 3 weeks, but probably shorter than, let's say, 7. So between, let's say, 4 and 6 weeks is a fairly good time to have the surgery.
Okay. Then the question about radiation. How can some patients, I don't know if it's an oncologist thing, get 15 sessions and then others get like 30 sessions?
So, I mean, it can be an oncologist thing.
Okay.
I think if you have an oncologist that is working in a fairly big cohesive unit and are exposed to, I want to say, frontline thinking and frontline protocols frequently, then they will be inclined to de-escalate quicker. So we know that doing little higher doses every day, but less sessions is as good as giving smaller doses over a longer period of time. Okay, so in principle, we say we can do that, but there are certain cancers, certain features that you'll say, okay, we can do 3 weeks, but we have to do a booster, which is another week. Boosters are really only of value in young patients, in patients who have cancers that are not nicely or excised fully. So patients who have high risk characteristics. So patients shouldn't have routine boosters. That cuts 1 week of therapy, and then there are some patients where you want to add sort of the supraclavicular nodes, and you want to add the lymph nodes inside the chest, and so your fields become so that you can't fit that into 15 sessions. So sometimes the cancer will dictate how long the treatment should be, and sometimes it shouldn't be. But so we normally will say we want to give the patient the least amount of treatment with the maximum benefit. But there are still some oncologists that sort of stick to that long 5.5 week treatment regimen.
Yeah, and then you are all blistered and red.
Yeah, I do think there are always, so even with hyperfractionation where you're giving that shorter course, there are still some patients that have, if your skin is really sensitive, you can still have that effect. But we do think that cosmetic results and the cancer results, I mean, definitely I think cosmetically it's better if you can do the shorter course But I think it's important to understand that your cancer will in a certain way also dictate whether you can have that or not.
The reason behind your radiation is to do what? So now you're clean. You've had everything done. You've had your mastectomy. Why are we doing radiation if everything's clean?
So cancer, so breast cancer is in principle also, there's no such thing as a breast cancer which is just a lump. Breast cancer is always a systemic disease. All right. That means that that cancer has pushed out little microscopic cells, which we call micrometastases. I think of it a little bit like little seeds that are washed through your body, and they are circulating around. They can't necessarily go and grow in a lung or whatever, but they are there. So, and also from the lump in your breast, those little cells will be in the lymphatic network, in the network that is around that area. And the last thing is, if you've developed a cancer in one place in that breast, we know that that breast has an inherent propensity to develop breast cancer. So you have to protect the area around where the cancer was as well. So in the old days, we would say, right, everybody needs to have a mastectomy. But then later on, we saw if you did a lumpectomy and you added radiation, it has the same benefit as actually doing a mastectomy. So radiation protects a much wider area than what you can actually do with surgery. So if you have a lumpectomy only and you refuse your radiation, 1 in 4 patients' cancers, if it's an average cancer, will come back again in the same breast. If you add radiation, that risk should be sort of less than 5%. I would venture to say 2 to 3%. So it makes a big difference in terms of the local risk of the breast.
Okay, but what I want to ask about the radiation, why aren't we allowed to use deodorant when we're getting the radiation?
So obviously with the radiation, it's like, that the radiation affects the skin. So you want to irradiate the inside of your breast, but obviously the beams are going through the skin into the breast. And now you're getting that effect on the skin surface. If you apply any chemicals to that skin, or if you injure that skin in some way, that skin is not going to be able to heal well. And it can actually sort of really end up as a big infection mess. And then you have to stop the radiation, or you have to and obviously if you give a little bit of radiation, that will actually induce cancer. If you don't stick to your regimen and you don't do the dose, so there's a dose that will cause cancer, there's a dose that will kill cancer, and then there's a dose that will kill you. So you want to have more than the dose that gives cancer. You want to have the dose that kills cancer, but you don't want the dose that kills you.
Okay.
Can I just, at this point, ask a question also relating to radiation and chemotherapy, but it's actually Miranda asked, after chemo and radiation, after seeing your doctor every 3 months for 2 years, what treatments or tests are required thereafter?
So, the follow-up regimen for breast cancer, so we would say the highest risk of your cancer coming back is probably in the first 3 years. And then for up until 5 years, there's still a significant risk for the patient. And then after 5 years, that risk becomes very low long-term. So we would say the first year and a half or so, we would normally see the patients every 3 months. Then we'll see them every 6 months up to 3 years, and then we'll see them once a year until 5 years. And then after 5 years, we will say you still need to have a mammogram once a year. You still need to have a clinical check of that is the important thing. Don't not see your doctor because you've had a mammogram. You have to have a clinical exam and a mammogram. And that you should have lifelong. So we don't tell someone after 2 years, oh, it's fine now, you can just go away and don't do anything. So you don't have to have all of the tests every time. So we do tests based on the risk. So if you have a very low risk cancer, then you can have a clinical exam and a mammogram, and that's it. If you have a very high risk cancer, then we'll do a CAT scan, bone scan, blood test, once a year and with a mammogram, and we'll still examine you in between with blood test every time. Does that answer the question?
I think so. I hope so. But another question related to that, Genevieve asked PET versus a CT scan. Would it be better to have a PET scan every 6 months after chemo, mastectomy, and radiation, or would a CT scan be enough? I was stage 3B, 9 lymph nodes involved.
So,
3B.
So I think every scan has different values to that. Not all breast cancers show up on a PET scan. So we do have some cancers that don't show up on PET scans. So number one is it depends on the type of cancer you have. Number two is obviously a PET scan is hugely expensive. It's about usually about 3 times the cost of what a CT scan would be. And obviously it does give you more radiation exposure than what a CT scan would do. And lastly, most PET scans don't use contrast, so your detail of what you're seeing is a lot less. So if you see something on a PET scan, you often have to still go and do another CT scan to then quantify exactly what's going on there. So for the time being, it depends a little bit on the risk that you have, on the type of cancer that you have, and how concerned your oncologist is. It makes whether if you have a scan every 3 months or every 6 months or every year or whatever, the frequency of how often you have scans makes no difference of whether your cancer is going to come back, whether your cancer is going to be treatable. If you have a cancer that had spread elsewhere in your body, that spread happened before you knew you had cancer. That little seed went there even before you knew you had cancer. And that seed has been lying there. You can do 20 scans, and then one day you'll see a lump. It didn't change the fact that that thing had been there for the past 5 or 10 years already. So doing lots of regular scans makes no difference in your outcome, but it exposes you to more radiation, so it increases your risk of getting cancers in other places in your body. So in theory, the advice is, unless you have symptoms that are concerning, you probably should not have a scan more than once a year.
And being a HER2 positive patient, and the medical aid wants it now every 18 weeks.
No, remember, medical aid is a person sitting behind the desk that has no medical training, that has a little list of tick boxes that they have to fill out, and they don't have to go for the test. They don't suffer the consequences of the test, and they're definitely not going to sympathize when you have another lung cancer or something like that. So I think if you have metastatic disease, if you're on active treatment, then unfortunately we do need to monitor that. But I mean, I have patients that have been on Herceptin for 16 years and, no cancer. And you can't for 16 years have a scan every couple of weeks. So at some stage you have to tell the medical, listen, I want to speak to your medical advisor. I need to have a sensible person that I can speak to, because you are irradiating me to death with your scans, even though I've survived my cancer.
Okay, ek gaan dit gebruik.
Okay, ek het nog 'n vraag hierso. Genevieve also asked, I'm ER and PR negative, but HER2 positive.
Yeah.
I've just been prescribed fatty thyme by my oncologist to help with the vaginal atrophy. Is it safe to use? I've had a hysterectomy but still have what's left of my ovaries. My gynecologist advised against any hormones as I'm prone to pulmonary embolisms and blood clots.
So short answer is Vagifem is a vaginal local estrogen. If you have a normal vaginal lining, almost none of that estrogen will be absorbed into your bloodstream, and it's then safe to use. I wouldn't advise using Vagifem in someone who's got an estrogen positive cancer, or someone who has actually already got lots of vaginal dryness and thinning, because then some of that Vagifem will end up in the bloodstream. And for those patients, we prefer estriol which needs to be mixed specifically for the patient. But in your case, it would definitely be advisable and safe. The problem is if you, with your chemotherapy, you would have now, your ovaries would have probably been knocked out and you have now, become postmenopausal. So unless we can show that your hormone levels are going back up again, it means that you do need that little bit of extra estrogen support for the vaginal lining. Otherwise, it becomes dry, it becomes irritated, it becomes thinning. You have numerous bladder infection. Sexual intercourse becomes painful. It can lead to lots of problems, which is then very difficult to turn around. So it's better to maintain than to try and rescue.
Miranda has a follow-up question. What about chest x-rays and sonars after treatment?
Again, I think the same principle is you can do 100 x-rays. So a normal chest x-ray, the dose of radiation that you're getting is about the same as a week's worth of sunshine. So it's very low and it's not going to cause cancer. Ultrasound obviously is sound waves. So having an ultrasound is very safe and is not going to cause cancer. So, but having hundreds of those things again is not going to prevent that little seed of cancer sitting in your lung that might pop out after 5 years. So if you have a very low risk cancer, let's say you have a lobular cancer, estrogen sensitive, node negative, the chance of that cancer popping out in your lung is like 0.2%. To have hundreds of x-rays for that is almost of no value. Then, so again, you would wait until someone has symptoms and then you investigate. If someone has a very aggressive cancer, triple negative cancer, HER2 cancer, then they need to have other scans and things a little bit more frequently, especially in the beginning. And if we see the patients doing well, we can then taper down on the number of scans and things that the patients have. But a chest X-ray and ultrasound is a cheap alternative to having scans, and it really doesn't make a difference whether the patient will survive their cancer or not. So in an average patient, it's probably fine to just have that. We use that for all of the years, and I still use that on selected patients. So yeah.
Then I've got a question, and we've done it before on the alcohol. The whole story about alcohol intake, it's got to do with estrogen. Eh?
Estrogen is one of the components. So alcohol in itself causes cancer, not because of estrogen, because it's a toxic substance that causes cancer. And it has lots of breakdown products. So if you ingest alcohol, some of that alcohol gets turned into formaldehyde, which is excreted in your sweat and which causes skin cancer, for example. So if you have 2 glasses of wine a week, it increases your risk of skin cancers by 30%. Okay. So it has nothing to do with estrogen. If you ingest alcohol, it increases your risk of tongue cancer and throat cancer and windpipe cancer very significantly. So alcohol in itself is a cancer-causing agent. If you ingest alcohol, it adds to the estrogen level. So that's why men who drink a lot, start developing boobs. So it does, what did Shakespeare say? It provokes the desire, but hampers the performance, as they say. So it gives them boobs where they don't want one, that makes other things shrink that they need, So in women, unfortunately, it does increase estrogen or estrogen-like levels, and it will definitely increase the risk of the cancer coming back. So unfortunately, alcohol is, it's like anything that someone wants to sell you. They will promote it and they will tell you how wonderful it is, and you have this beautiful photo with the sunset over Table Mountain and this glass of red wine that someone's sipping, and it looks so fabulous. And but the reality is, it is a lie that's being sold to you.
I've got a question. Can you color your hair after you've had chemotherapy?
Obviously, you can.
I've had
So the answer, yeah, and I get phone calls from hairdressers and people that say, oh, doctor, I just want to make sure Mrs. X is here with me and we want to color her hair, but am I allowed to do that? So the answer is yes, you can. Obviously, if you just finished with your chemotherapy and your hair is that short, and you still have all kinds of symptoms from your chemotherapy or whatever, then maybe not such a good idea to rub some extra chemicals on your head. But I think once you've stabilized and things are going well, there's no reason why you can't.
I want to ask, so the story behind the red devil, it kills off fast dividing cells, so you lose your hair. Why
Yes.
don't you lose your eyelashes and your eyebrows on that?
But no, it just takes, I think it's about how fast things grow. So your hair on your head grows much quicker. And therefore, if you stop the new cells, then they will fall out much quicker. Your eyebrows will fall out as well. There are a few patients that are fortunate that don't lose their eyebrows, but most people do. And in the old days, when we used to just do 6 of the red chemotherapies, they would still lose their eyebrows, but they would lose it a little bit later than what they would. And it's just because they grow a little bit slower, they're a little bit coarser hair, so they stick a little bit more. Most women will understand that if they have to wax them, so they're resilient little buggers.
Another question is the nails. Why with the Taxol do you get, I'm not sure if it's with the red devil, but with the Taxol you get that browning or the nail beds?
Again, it's both the chemos does that, and again, it's because the nail is much slower growing. You will sometimes see that the patient will say, well, my hair's fallen out, and then only like after 3 months or so do I see my nails giving problems, and then the toenails even later than that. Sometimes even like a year down the line, the toenails will just come loose or whatever. So it's just because at the speed of which those cells grow. So if you knock them for a period of time, the effect of that is going to be seen later on just because they grow slower.
Then the other question I have is, so now this October month, everybody's going to go for mammograms. So now you go like me and they tell you there's a lump. So now you're already in panic mode. Now you want to see the doctor, but Dr. Ettienne is book bumper. So now you can't think or sleep. What is the time limit that would be okay for you to, from the day that you get your mammogram and it's positive till you see a surgeon? What would that look like for you? Within how many weeks?
So I think in principle, we want to try and see that someone starts with some sort of treatment within about sort of 6 weeks. It's not a long period of time. So now start of treatment doesn't mean that you have an operation. So in theory, lots of stuff can happen in between, and you can have that. The average cancer, if you have a fairly slow growing estrogen sensitive cancer, in theory, even 3 months will probably not make any difference. But if you have a triple negative or a HER2 positive cancer, then 6 or 8 weeks can certainly, if you then go to 8 weeks, it can start making a difference in terms of the size of the tumor. So, but I think the important thing is, it's not as much how long can you wait. The important thing is you do not have to have a mastectomy the second day after the biopsy result.
Yeah.
And in fact, you shouldn't have a mastectomy. Anybody that advises a patient today and say, ma'am, you have cancer, I'm going to book you tomorrow or the day after for an operation, that is 1975 all over again. We don't treat cancers that way. So firstly, you make the diagnosis, and you don't just want to know it's cancer or not. You want to know, is it cancer? What type of cancer? What are the estrogen, progesterone, HER2 status on that? Then you want to have staging investigation. You want to know whether the cancer had spread. Now, if it's a very small cancer, you don't have to do lots of stuff, but especially if it's a HER2 positive cancer. Number 3 is you actually want to know whether it's a genetic cancer. So you want to have a genetic test if you're a young patient, if you have a strong family history. So there are lots of little things that need to happen. So even though if someone phones me today, I'm not going to see them tomorrow and I'm not going to have an operation in 2 weeks' time, there's lots of stuff that's going to happen in that period of time. So they are already in a process of being sorted out, even though they haven't seen me personally. So we have a whole team of people that are already sort of starting to manage that. And I think that's the important part is once you get diagnosed is to find yourself a team of people that will help you manage your cancer. So you cannot bear this burden alone. You cannot do everything alone. You need good advice to make good decisions, and I think that's the important part. So, but I mean, the reality is now after lockdown, we are seeing a massive surge of cancer patients that are coming out, some with really big cancers. But that's why it's so important that not every cancer gets an operation up front. About half of the cancer should actually get either chemo or an endocrine therapy up front before they get their surgery, because then by the time I do the operation, I know already whether this cancer is sensitive to the treatment or not.
So patients that had a lumpectomy, or they've had surgery and now they get chemotherapy. Mm-hmm. Now you do the scan. Now you don't know. So you don't know if it's whether it would have shrunk or not because you've taken the.
You don't have anything to measure. Yeah, exactly. So you're giving the chemo routinely, blindly, and you say, well, so in theory, if you have let's say you have a typical breast cancer that's got one node positive, maybe let's say 2 centimeters in size, estrogen positive. If you have 100 women with that cancer, about 70, let's say 75 of them, if they had no chemo at all, they are going to be survivors regardless of what you do. If you just do an operation, they will be fine for the next 10 years. So now you end up with, let's say, 20, 25 patients who, if they don't get something additionally, they are going to, okay. Of that 25, you're probably going to have, depending on the age of the patient, anything between 3 and 8 that will die of natural causes. Car accidents, heart attacks, strokes, whatever. So now you end up with, let's say, 18 patients that will die of their cancer. If they're estrogen positive, you will save the life of maybe 5 or 6 of those patients because they're taking anti-estrogen treatment. Now you're down to, let's say 12 patients. And if you give chemo, you're going to maybe save another 5 or 6 lives. So you're giving chemo to 100 people so that you can save the life of, let's say, 5 or 6 people. That's why when I sit down with a patient, I say, this is the block. This is the 100 women that's in your ballpark. Let's look at the real benefits. If you have to treat 100 people and you maybe just save 1 life, then it's probably not worthwhile, because with the chemo, you might actually kill 1 person. So you have to make sure that your benefit of the chemo at least is maybe 3 patients to start making a benefit for people getting chemotherapy, because you're giving it blindly. If I have the patient up front and I can see the tumor and I know that it's a big bad tumor and I see that it's shrinking, then I know, listen, I'm hitting the right target. I want to get to that end point where there's actually no cancer left.
So that point now, when you do the mastectomy and you send it off to the pathology people, what is the different kind of results that you get there? So you'll get, will there always be cells left, or most of the time nothing
left? After chemo?
Yeah.
So it depends on if you have a HER2 positive cancer, estrogen negative HER2 positive cancer, about 60, even as high as 65% of patients who, by the time you do their surgery, you don't want to see any cancer there, or you shouldn't see any cancer there. And that means that the patients had 4 cycles of red chemotherapy, anthracycline, and they've had 4 cycles, which means 12 weekly doses of paclitaxel usually, and they have had Herceptin with that paclitaxel. That is probably the best regimen to get rid of that cancer. And if you're in a very good medical aid, you can add pertuzumab to the Herceptin or to the trastuzumab, and that would push it up to maybe like even 70, 72% of patients that should have no cancer left in their breast by the time you do their surgery. So theoretically, you don't have to do a mastectomy. You can just remove the bed of where the cancer was to see what's left. Okay. If you have a triple negative cancer, you should have about sort of 50% of the patients, where maybe sometimes even a little bit more, but that there should be no cancer left behind, not even one cell. If you have an estrogen positive cancer, remember estrogen is still the thing that drives that cancer. Even the bad ones are not that chemosensitive. So you'll maybe have anything between sort of 10 to 15, 20% maybe that would have a complete response that there's absolutely nothing left. But remember, they still have to have the estrogen treatment.
So now you're left with a few cells, the other percentage. So what happens now? Do they need to get a mastectomy to get rid of that and radiation to make sure that it's now all gone?
So everybody that has breast cancer will need to have surgery after they've had their chemo or the upfront treatment. Okay, so you still have to have an operation. You can't have treatment and then everything shrinks away and then you just decide, okay, now I'm going to go on holiday. So everybody has to have surgery. Okay. Now, if there's something left, we will then make a decision to say, okay, so obviously you need follow-up treatment. You can't just, you're not happy that everything's dead. So if you're an estrogen positive, you will continue with your anti-estrogen treatment. If you're HER2 positive, you will continue with HER2 treatment. But if you're triple negative, you don't have any of those things. Those are the patients that we would then say, okay, maybe you should have a chemo tablet and continue with that for maybe even the data now says maybe another year of taking a chemo tablet. And we add things like, for example, bone protecting medication, things like Zometa or Zobone or a cluster. And we know that that also reduces the risk of the cancer coming back. So we add other treatments to try and reduce that risk because the triple negative patients don't have follow-up treatment that can help and protect them, like we do with estrogen positive cancers or with HER2 positive cancers.
I've had one lady contact me. She, on a biopsy, she was triple negative, and then when they did a mastectomy, it came back as estrogen positive. Is that a...
So let's say, the estrogen receptors will die very quickly. So let's say you do a needle biopsy, and they're struggling, and they taking it out, and they fiddling, and blah, 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 and that biopsy lies there, even for, let's say 10 minutes, and then only do they put it in the formalin which fixes the tissue. Then those receptors will die, they'll go away. So when you then stain the tissue, then they don't stain, they don't show up. So it's very important the way, again, so good breast cancer treatment starts with how the biopsy is done. It starts with, how the mammogram is done. It doesn't start with me operating the patient. So good use, making, a good efficient biopsy, using core biopsies. We never do fine needle aspirations for breast cancer. We do core biopsies or vacuum biopsies. You want to have a nice chunk of tissue. We don't go and excise something to find out what it is. So core biopsies or vacuum biopsies, going into formalin immediately. Once it comes out of the breast, it goes into the formalin. So then you have the most accurate answer as to what's going on. So in a case like that, I would be suspicious that the biopsy specimen maybe became degenerated and the receptors didn't show up on the staining.
So would the treatment differ from being triple negative to being estrogen positive after a mastectomy?
It would, obviously, because if you're triple negative, you always have to have chemotherapy, unless you maybe have like a 2 millimeter cancer.
Yeah.
But if you're triple negative, you have to have chemo.
Yeah.
If you're estrogen positive, most of those patients do not need to have chemo.
Okay. Yeah.
So they will have anti-estrogen only, and they'll only have chemo if they are really bad and aggressive cancers, or if the Mammoprint is a high risk, for example.
Then a question on the paclitaxel. Is it again an oncologist thing, where you get it either 12 weekly once, or you get them 3 weeks apart? But I know sometimes they do it when patients live far.
Yeah, so I think, maybe there's logistic reasons, but so if you look at the NCCN is a big national cancer network. They have an advisory board, and so they would say that the best chemotherapy regimen for breast cancer is what we call dose dense AC, which is the red chemo, which is then given every 2 weeks times 4, followed by weekly paclitaxel. So that is considered to be the best regimen.
Golden standard.
There's very little difference, if you give that if you give Taxotere or if you give it every 3 weeks. But the problem is now you're giving a bigger dose, so the side effects are more, the bone marrow suppression is more. So in the end, it's about giving the most effective therapy and getting the patient through the treatment in the most efficient way.
So are you allowed to tell your oncologist you've heard that you
Yes.
can get it weekly? Can I get it weekly?
You can definitely, that's part of what support groups are about, and social media groups and stuff like that, is to be empowered and to say to the oncologist, listen, explain to me why am I getting this every 3 weeks if I understand from everyone else that they are getting it on a weekly basis. And if you have a good doctor, they will not be offended and they will say, no, sure, the reason why we're giving you this is because of A, B, C, and D, and E. And, you are, in the end, I am, what is my job? My job is to advise the patient as to what the options are, and there are very seldom just one option. It's my job to advise them which options are better and what are the pros and cons of the different ones, and in the end to guide my patient to try and allow the patient to make the right decision. But it's still the patient's choice of not only whether they want treatment, but also what treatment they think would be best for them.
And the last question I have is on a bone density. Do we need to go for bone densities? I think you go for one when you normally get diagnosed. I think I went for one, but what happens? Do you need to have a follow-up one? Is there any reason?
Yeah, so so bottom line is, if you are postmenopausal, if we make you postmenopausal, then you have to have bone density scans. Now, you're not going to, if you're 35 or 45, you probably are going to have one at some stage and then quite a long gap. But let's say you're 55 or 65 and you have an estrogen positive and we're treating you with anti-estrogen treatment. So everybody that is on an aromatase inhibitor, so those are the letrozoles and the Aromadex and Equicin and Aromasin, those type of things. Those patients all need to have bone densities, and probably, if things go well, at least every second year, because they are at an increased risk of developing osteoporosis. And it's very difficult to turn the osteoporosis around once it develops. So you actually want to see, if you see the bone density is going down, you want to start treating it preemptively. In someone that is, that is not an anti-estrogen treatment, in theory, you don't necessarily have to do it that frequently. But I think one also has to look, family history, if you're a fair person, if you have light-colored eyes, if you're thin and tall, those are the patients that are at increased risk of getting osteoporosis.
Okay, I think I've got one more question for, if you're under 30, when would you advise a genetic testing? I know you had to think, if you're under 30?
Everybody, everybody that gets breast cancer under the age of 50 should definitely have a genetic test. Or if there's anyone in your family that's had ovarian cancer, or if there's any male person in your family that's had breast cancer, or if there are people that have had breast cancer on both breasts, or if you have more than 2 relatives, first line, like let's say a mother and a sister who's had breast cancer. So even if you're 70 and your mom's had breast cancer and your sister, you should have a genetic test. So that's really important.
Goed, ek het wil net sê Linda, ek het nie van jou vergeet nie. Ek gaan nou Linda's vraag net weer gou vertaal. Linda sê, I'm turning 60 in November and I had a full hysterectomy about 5 years ago. My doctor prescribed Mammoprint last week. Will it make a difference if I tell him that I had this hysterectomy, because I can't remember whether I told him?
Linda, the answer is no. It doesn't make a difference. So you don't, when you do a hysterectomy, remove the womb. the womb doesn't really produce any hormones. So whether someone's had a hysterectomy or not doesn't influence whether they need anti-estrogen treatment, yes or no. So it would make no difference, if you told that or didn't, or omitted to tell the doctor.
Okay, then Yolandi asked, as you explained that breast cancer is a systemic disease with micrometastasis, will chemotherapy cure these micrometastasis?
Yeah, so the idea behind this is that...
Sorry, I didn't complete the question. I mean, if you have 2 centimeters of estrogen positive and chemo not indicated.
So if you have, so remember, chemotherapy will only kill cells that are actively dividing. It's not going to kill cells that are resting. And so that means that, if you have an estrogen positive cancer and let's say only 10% of those cells are busy dividing, normally they will do a marker that we call Ki67. And if that value is, let's say, 10%, giving that person chemotherapy, of that 10% of cells, you might kill 2%, and the next session you'll not kill another 2%, but you're leaving 90% of the cells that are in the resting phase that the chemotherapy does absolutely nothing to. So it would make no sense. So if someone has a Ki67 of 90%, then yes, it would make sense, because now you have 90% of cells that are actively dividing, and chemotherapy might kill 20% of that with the first session, another 20%, another. So the higher the proliferation is, the more of an effect the chemotherapy will have. But in principle, with a patient that has got an estrogen-sensitive cancer, we know that the fact that the cancer is driven by estrogen means that the cell can switch off it can switch that off. So chemotherapy is never as effective in an estrogen positive cancer as it is in other cancers, for example. So you don't give chemotherapy just for, let's give a laxeltjie chemo just in case. That doesn't work. It only makes things worse, because then if the cancer ever comes back, you can't use that same chemotherapy again. So you want to make sure that if you give chemo, you give it for the right reason, that you give it at the right dose, and that you complete the dose. You don't want to give, like, let's do 2 sessions of the red chemo. The cancer is shrinking nicely, let's stop now and do the surgery. Definitely not. You don't do 4 red ones and then stop and then do the surgery and then give the taxane afterwards. No, you don't do that. If you decide you're going to do chemo, you do a full course of chemo, because every time you disrupt that, you will make the chance of resistance to the chemotherapy more. So very important to complete the chemo. But in a typical estrogen positive cancer, very little benefit, and you have to have a good reason to do that. And that's why we say, if someone has a 2 centimeter estrogen positive cancer and they have maybe, let's just like 1 or 2 lymph nodes, we still see that almost 60% of those patients, if you do a Mammoprint, they come back as low risk. In other words, they're going to gain no benefit from getting chemotherapy. So you don't say, well, let's do it just in case. That is killing yourself with no benefit.
So why do HER2 always have to get chemo?
Because they normally have a very brisk turnover. It's a technical issue, but not all HER2 cancers that we measure just on the normal stains are truly HER2 positive. But if you have a cancer that's HER2 positive and your proliferation is 90%, then those are the ones that, so those, and the proof of the pudding is when you treat them with chemo, then they all die. That tells you that it's a very chemo-sensitive type of cancer. So.
And the other question is, can you get red chemo again? I've heard some.
Not, in principle, not in the same effective way that you've had it before. So if you've had red chemos, you are limited at how much you can get over your lifetime. And let's say your cancer then comes back and you have metastatic disease, we definitely will try lots of other things before we go back to an anthracycline, and then we'll use it in a different format. We won't use the same anthracycline that you've used before.
Okay, I've got one last question about the brain metastases. I think that is something that sometimes freaks me out, because you always, does chemotherapy go into the brain?
Chemotherapy does.
does.
Not all of them, but yes.
Yeah.
Yeah.
So now you've been going. So you can't scan to see is there something. You've got to wait for symptoms.
You can scan. Obviously, you can do an MRI of the brain.
Yeah, but we obviously aren't going to expose ourselves now to do.
But now remember, MRI is not radiation. MRI
Okay.
is magnetic, and it doesn't. So there's no risk to an MRI except for your wallet, but not to your body.
But you're not going to gain benefit by doing an MRI every 6 months because you can only treat this when it's there.
Yeah, again, yeah, exactly. So you are going to wait. But I would have a low threshold. Normally, we will normally do an MRI for HER2 positive patients. We want to do a baseline MRI. There are some oncologists that will do one every year to check. But I agree with you. The fact is, you're only going to treat something if you see it or if it's there. So, and because your brain tends to give you symptoms quite quickly, it might be very vague symptoms, headache, sort of double vision, maybe a bit of nausea, stuff like that. So if I see someone and they have symptoms that I'm worried about, I will normally say, okay, listen, if it's mild symptoms, I'll say, okay, if it doesn't go away in the next 3 or 4 weeks, then we do an MRI of your brain.
Yeah, but that will not work.
But
Dit freak out.
I weet, yeah.
3 weeks.
So the reality, so if a patient is obviously concerned, if they have symptoms and they are concerned, then I will have a low threshold to do an MRI brain if someone has any sort of symptoms that they're worried about. But the reality of cancer is what you have to know. It's like, so every time you get on an airplane, there's a chance that airplane can fall. But you sort of, for some reason, you don't think it that way. Airplane is not a good idea. Every time you go away for Easter weekend, you have a fairly good chance that you can die in a car accident or that you can be severely injured. So for every one person that dies in a car accident, there are 8 people that are severely injured. Okay. So if you think about how many people die in a car crashes over an Easter weekend and you times 8, then it gives you an idea of what your risk would be of having a really severe bad Easter weekend. And somehow everybody gets in their cars, happy, smiling, and go merrily on their road. But if someone says there's a 0.1% chance that you can have a brain metastasis from your breast cancer, then it's like every time every thought is like, maybe it's today, maybe it's today.
Yeah.
So I think, and that is why, things like cognitive behavioral therapy, but Romans 12 says you have to renew your mind every day. The concept of, I always say you have to think what you think about, and you have to tell yourself whether this thought has authority and has power or not. Because otherwise you will be completely disabled and maimed by the threat of something that might happen.
Oh, no. Yes, and 2 other very helpful questions would be to ask yourself, is this true? Do I have facts to prove that what I'm thinking is true? Is it logical to think in this way? And then the second very important question is to ask yourself, does it help me to think in this way? And if the answer is no, if you've got no, the answer is no to both those questions, then you must really try and ask yourself, how can I think in a different way that's going to help me? It's going to be based on facts, and that's going to make me feel at least not worse, but hopefully a bit better.
Yeah. No, that is very true. So I think the one thing about cancer is to understand that it's a mind battle. And if you struggle with that, then you do need help. It's like physical exercise. You don't become fit by sitting in your chair. You don't become mind fit by just allowing every sort of slap the life gives you to knock you this way and that way. You have to practice that.
Yes.
And you have to, every time that thought pops up, you have to immediately say, terug is jy. Verstaan? So we are not irresponsible. We don't walk for, like some patients I've seen now, for 6 months with this thing growing out of your tongue or out of your something, and because the doctor gave you antibiotics in April over the phone, that you just decide, listen, it's obviously nothing. No, If the doctor 10 years ago told you this lump is a lipoma and it's gotten this big, it's not a lipoma, then it needs to do something about that. So we need to be sensible, but we shouldn't be completely paralyzed with the expectation that something is going to happen really bad now. It's an important thing. It's the thing that makes people run away to Australia and to New Zealand because they read the newspaper that says they found a baby in the drain. It's terrible, but it wasn't their baby, and they mustn't make the newspaper their reality. For the same reason that you shouldn't make other people's cancer problems your reality. The fact that someone died or had a brain metastasis or something bad happened, it's bad enough to have it for yourself, but you shouldn't make other people's bad things happen to you, even though it hasn't. So it's important to live one day at a time. If you've had a scan, your cancer's come back somewhere, then you say that's okay. We take what we have now. This is the reality we have now, and we devise a plan. None of us will live forever. I know some people think that way, but the reality is even the healthiest of persons will die one day. So, okay.
Yeah, I actually feel like I wanted to share a story about my dad. I think my dad was diagnosed with cancer when he was in his early 30s. And I think most of his friends sort of said, shoo, shame, poor Alec, he's going to be the first of us to go. And then he was actually treated and he was cured from the cancer. And he's 76 years old now. But he was diagnosed in his 40s with diabetes. And then again, they said, okay, so Alec's going to be the first one to go, and sort of started thinking. And and I don't know, by the grace of God, my dad's still with us. And actually, all those friends who said, well, not all of them, but more than half of those who said that Alec's going to be the first to go, actually went before him. So we never know when it's our time. And yes, and cancer can be cured. That's just my dad's.
Yeah, and I think that there are many people that have died, 20 years ago, and they were only buried very recently. So you shouldn't stop living before you're dead.
Yep.
And I think that's what this disease can sometimes do. It can paralyze you. It can, take away your living before you're dead.
Okay, we still have one more question. Erica's asking, I'm taking Tamoplex. My oncologist suggested that I take it Monday to Friday. Would you suggest 7 days a week?
So sometimes if patients really struggle with, getting started with this, sometimes we'll say, okay, let's try doing it. Let's try making you used to it. So you use it like, 5 days a week or something like that. But I think, if you're taking it for invasive breast cancer, then in principle it is better to take it every day. There are some situations in situ cancers or risk reduction use chemoprophylaxis that we might use lower doses or we might use different frequencies, but in principle it would definitely more advisable to take it once a day. I think the evidence that we have seems to suggest that rather.
Okay, and then Mel says that she really like Dr. se pink dots.
Daar's hy. Thank you, Mel. Baie dankie.
I think that's all the
Yeah.
questions that I have.
I hope it was an informative, maybe not, I don't want to say entertaining, but at least informative. Lori, ek hoop ek het jou vrae alles beantwoord.
Yes.
And thank you, Lori, for the initiative. We are always looking for, remember, this support group, this In the Cloud support group that we've now had since lockdown, is not for us. I don't need to hear my own answers. So it's for you. So we want you to please give us feedback, to tell us, listen, we want this, we want that. This is stuff that we would really appreciate, because then we'll try and make a plan to do that. If this sort of Q&A type of sessions are good, then we can do another one. If you want to say, listen, we want to know, we don't like Dr. Meyerberg's tie. Get an oncologist on board, then we get an oncologist. So please, you can send us WhatsApps. You can on the YouTube. You'll see now. Obviously, this was a live feed on YouTube as well, and it will be available afterwards to check. But you can leave comments there. We get those by email. You can send us emails on our website. There's a contact form on Lori's YouTube channel. There's contact details on her Facebook page. So please, yeah, let us know, and we'll try and make a plan to sort of, yeah, give you something of value. The idea is really to add value to the people outside there. So yeah, why don't you left?
Yeah, I would just also like to thank Lori Ann. Thank you very much for compiling this list of questions, and Etienne for providing the answers. There's a few messages here, people saying that they found it very informative and very helpful, and that it means a lot. So thank you, both of you, very much.
Okay.
Okay.
All right. Lekker bly julle. Bye.
Bye.